Hello, everyone. My name is Hamera Osman. I'm the VP of Research and Public Policy at Muscular Dystrophy Canada, and welcome to today's Let's Talk Neuromuscular Disorders, Let's Talk NMDs webinar series. Today's session is on treating infantile onset and late onset Pompe disease. And today we have Dr. Inberg Feigenberg, who has completed her pediatric training at Hadassah University Medical Center. She completed a clinical biomedical genetics fellowship training at the University of Toronto in 2015 and joined the Division of Clinical and Metabolic Genetics as a staff metabolic geneticist in 2016 at the Hospital for Sick Children in Toronto. Her research is focused on lysosomal diseases and the impact of new interventions. Today we're really excited to have you here today, as you'll be able to present us a different perspective, a perspective from a metabolic physician on Pompe disease. We have heard from neurologists and really excited to hear from you as well. So thank you so much for agreeing to give this presentation, and over to you.
Thank you, Mira, and thank you very much for the kind introduction. I'm trying to share my slides. Okay. Do you see my slides okay?
Looks perfect. Over to you.
Okay. So as Mira introduced me, I am a pediatrician, and I'm also a metabolic physician, metabolic geneticist. And today I would like to focus on Pompe disease, the presentation and treatment in children. These are my disclosures. A brief review. Pompe disease, also known as glycogen storage disease type 2, is a progressive lysosomal storage disease and a neuromuscular disorder with an autosomal recessive inheritance, meaning you need two non-working copies of a gene to have a condition. The disease is caused by deficiency of an enzyme called acid alpha-glucosidase. Moving forward, I will call it GAA, resulting in accumulation of glycogen within the lysosomes of cardiac and skeletal muscle, leading to its destruction. The clinical spectrum is broad, and we see symptoms start as early as infancy and even in neonates, and sometimes we see it later in childhood, adulthood, and the disease severity is associated with the residual enzyme activity. If you have more enzyme activity, you will have a less severe condition, and if the enzyme activity is close or at zero, there will be a more severe presentation. The incidence of Pompe disease is different for different ethnicities and geographic regions. It is more common in African American and in the Netherlands and in the United States than it is in Portugal. And there are only few cases described, for example, in Finland. The incidence is also changing based on our growing understanding on how many cases of Pompe disease there are. And one of the contributions of newborn screening for Pompe disease is that for those countries that perform newborn screening, we suddenly see a much higher incidence of Pompe disease than originally was reported. And you can see, for example, Taiwan, that was one of the earliest, if not the earliest, countries that started newborn screening for Pompe. You see that now it is significantly lower than it was, that the incidence is much higher, than it was originally reported. There are two main subtypes for Pompe disease. There is the classical infantile onset Pompe disease, which I will refer to moving forward as IOPD. It is a rapidly progressive form, the more severe type, that is presenting shortly after birth with a cardiac disease, and if not treated with enzyme replacement therapy, unfortunately death within a year of life. And there is the late onset Pompe disease, which we call LOPD. This presents any time after the first year of life to adulthood, and does not and patients that have LOPD do not present with the classical cardiac disease we see in IOPD. They do not have cardiomyopathy or cardiorespiratory failure. The subtypes will be determined, as I said earlier, the subtypes will be determined based on the residual enzyme activity. And IOPD, in IOPD, the enzyme activity is usually 1 or less than 1%, and with LOPD, it is between 2 to 40% of normal controls. And the incidence of the subtype is usually a third to two-thirds. Around third of the patients will have IOPD, and 2/3 of the patients will have LOPD. So LOPD is more common than IOPD. I would like, in the next few slides, I will describe the pediatric or the presentation in children that have IOPD and LOPD, and the presentation is a little bit different. Patients with IOPD present mainly with hypertrophic cardiomyopathy. There is significant cardiac disease. Cardiomyopathy is some thickening of the cardiac muscle, and you can see here a picture of a normal ventricle. You can see the ventricles here. You can see that here on the left side there is some thickening of the muscle of the heart. A patient can also have cardiomegaly, big hearts, and abnormalities in ECG. Those patients also have proximal muscle weakness and proximal and what we call axial weakness as well, with a poor head control. They will have hypotonia, and as a result of that, they will have delayed motor development. And because of weakness of the respiratory muscles, they will have respiratory insufficiency. Many of them will require BiPAP, and in some cases of IOPD, they also need invasive ventilation through a tracheostomy, through a small incision in their neck. Children will have problems with swallowing and coordinating swallowing, and they will have feeding difficulties, and as a result, they can have failure to thrive. And some children with IOPD require nasogastric tubes, which is a small tube that goes through the nose to the stomach to feed the child, or what we call a G tube, which is a tube that goes directly, a feeding tube that goes directly to the stomach. On physical exam, these children might have a bigger liver that we can palpate, and we call it hepatomegaly, and a bigger tongue, which we call macroglossia. Children with IOPD have speech disorders. It is very common in all type of Pompe disease pediatric patients. We see it more in IOPD. We can definitely see it also in patients that have LOPD. Hypernasality is the most reported speech impairment in children that has Pompe disease. And if we are doing blood work for these kids, very early on, we will see elevation in the CPK levels. And as I said earlier, if we will not treat these children with a disease-specific treatment, we will see a significantly shorter life expectancy. And this is the contribution, the huge contribution of enzyme replacement therapy to patients that are diagnosed with IOPD. There are a few pictures that I wanted to show you, and I'm sure many of you saw before. This little guy is actually a picture from a video made for the Australian Pompe Disease Foundation. This little guy, and you have the link here, this little guy unfortunately died at 2.5 years of age, and his mother made this video to advocate for newborn screening for Pompe disease. When you look at him, you can see that he has muscle weakness. He can't support himself when he's seated, and he required a help of a chair. He's fed through a nasogastric tube. His tongue look a little bit bigger. If you look at this neonate, you can see that he is weak and cannot support his neck when the physician tries to rise the baby up. And there are few other genetic conditions that can cause hypotonia and what we call head leg on physical exam for infants. But once a physician will do an X-ray and see the very big heart, the cardiomegaly, the diagnosis of Pompe should be suspected. The clinical presentation of children that have LOPD is different. Children with LOPD mainly present with muscle weakness. The presentation of LOPD is more variable, and so is the rate of disease progression compared to IOPD. Some patients, and most of the patients will present with weakness and will come to medical attention as adults, but interviewing those adults they many times report history of symptoms that can be tracked back to childhood, and even some of them to less than 1 year of age. So LOPD is definitely a disease that is seen and many times treated more commonly in adults than in children, but a good history can lead us back to childhood also with those patients. The most common presentation is what we call limb girdle weakness, basically weakness of the area of the shoulders and of the hips, some more weakness of lower extremities and the trunk muscle. Patients report difficulties with gross motor activities, such walking and running and climbing stairs, trying to get up from a lying position, exercise intolerance, and being fatigued easily. These patients, as I said earlier, do not have the cardiomyopathy that we see in IOPD, but they have quite significant respiratory disease, and this can present with respiratory insufficiency, nocturnal hypoventilation requiring BiPAP, overnight sleep apnea, and they can also have a susceptibility to respiratory infections because of a weak or an ineffective cough, basically weakness of the respiratory muscles. The respiratory disease usually come after the patient already have some muscle weakness. But in medicine, nothing is always the same, and there are some reports of respiratory weakness before muscle weakness. Usually the opposite is true. Children specifically that are diagnosed with LOPD and present with this with clinical finding early on can have delayed motor skills together with the progressive muscle weakness. So we see that gross motor on development in these children are not always on par. The symptom duration is the best predictor of skeletal and respiratory muscle weakness. An early manifestation of the disease at the age of less than 15 years implies early wheelchair or ventilation dependency and a more progressive course. There are other features to LOPD that are not respiratory or muscular. These patients can have heart rhythm changes, what we call arrhythmias. So there is some cardiac findings that we can find. It is not the typical cardiomyopathy that we see in IOPD, but we need to do some monitoring of the heart as well. There are reports of chronic pain in children with LOPD, and there are some complications as a result of the muscle weakness, like kyphosis or scoliosis, that many times will need also medical attention. Once we see the clinical features of Pompe disease and we suspect Pompe disease, we would like to diagnose the condition. And the diagnosis have two steps. We need to do an enzyme activity testing and confirm the low enzyme activity. And at the same time, we will do a genetic DNA testing and try to find variants, disease-causing variants, or what we used to call mutations in the GAA gene. Muscle biopsy is not a standard method to diagnose a patient with Pompe disease, and a negative muscle biopsy does not exclude Pompe disease. There are some clues to the diagnosis that we can get if we do EMG and see myopathy on EMG, or if we send a specific urine biomarker called glucose tetrasaccharide or HEX4, but those are not diagnostic. Those are supportive, or they can help us, clinically monitor the patient. A little bit more about the genetics of this condition. So GAA is the only reported gene that is associated with Pompe disease, and there are many mutations that have been reported to be found in that gene when this gene is sequenced. There are some genetic variants that are associated with specific disease presentation. So we can report what we call in medical language genotype-phenotype correlation, meaning some specific variants that are associated either with LOPD or with IOPD. For example, there is a common variant that you can see here on the screen that is very associated in patients that have LOPD. In different populations, we see common variants that are common for that population. For example, there are two variants that are also called the Dutch mutations that are seen, that are seen in the Netherlands and are more associated with IOPD. There is a severe mutation that is associated with IOPD in patients of Northern African descent, and there are specific variants that are associated with a significant IOPD in China and Taiwan. Another thing for us to remember is that sometimes we see what we call pseudoallele. These are genetic changes that lead to reduction of the enzyme, but not to a level that it will cause Pompe disease. And for example, we know that there are two common variants that are more popular or seen more commonly in the Asian population. This is why we always need to do enzyme activity and genetic test and pair the two in order to confirm a diagnosis. So I spoke with Humira earlier, and I understand that there was a talk that already discussed newborn screening for Pompe disease. I would try to be brief about it then. Newborn screening is an optimal approach for early diagnosis and treatment of IOPD. Right now, the median age for diagnosis of IOPD is 4 months. It seems that it is young, but at the same time, it's not young enough. And the babies we diagnose with IOPD can already present with muscle weakness and significant heart disease and respiratory issues when we diagnose them. Having a newborn screening and diagnosing soon after they are born can help the prognosis, can give better outcomes for these patients. And there is a study that came from Sawada and colleagues, which look at what happened in Taiwan and Japan, and they report that patients that diagnosed with Pompe disease that were screened by newborn screening demonstrated survival rate and ventilation-free rate that are better compared to those who were diagnosed based on clinical disease. And there are few other papers that clearly state the benefits of newborn screening to patients that have IOPD. However, if you remember my second slide about incidence, discussed that now we see that the incidence of Pompe disease is higher. It is higher because we diagnose more patients with LOPD than we originally thought. And when we discussed LOPD, we said that it is mostly presented with adults. When it presents in children, it is the more severe case. And then there is a question of when we diagnose patients based on newborn screen and we are screening enzyme activity, then we will diagnose patients that also have LOPD that for many years will not require a treatment. And then the question is, what happens to these patients? And for example, if their family is very anxious, their parents are very anxious as a result of the newborn screening. I will get back to this point in a few minutes. In the slide you see now, which is from 2020, so I'm sure that there are updates to this one. But you can see basically the countries that currently perform newborn screening for Pompe disease. It is done in Taiwan, Japan, 28 states in the United States, Italy, Hungary, Brazil. And this is what happens in the United States. So everything that is green is currently screening for Pompe disease. And the screening in the United States started in 2015, after Pompe disease was nominated in 2008 and was not entered into the did not enter the screening program. There was a decision to screen in 2015. One of the reasons, again, to advocate and for newborn screening in Pompe disease is supported by a paper like the one that Prosser and colleagues published. They basically developed a decision analytical mode to compare Pompe disease newborn screen with clinically identified patients with Pompe disease. They estimated that there are 4 million babies that are born unscreened each year in the United States, that this will detect 134 patients, and out of those patients, 40 patients will have IOPD and 94 will have LOPD. The analytic model led to the estimation that for IOPD, by 3 years of age, newborn screening will avert 13 deaths and will decrease the number of individuals requiring mechanical ventilation by 26. So it is very significant for patients with IOPD. So what happens in Europe? I think the longest experience reported is from Italy. The team in Italy have been doing newborn screening for Pompe disease over the last 7 years. And they have reported 11 patients diagnosed with Pompe disease. 3 of them had IOPD, 8 had LOPD, and they report, and looking longitudinally over the years, they report that all of the IOPD patients were treated promptly and had good outcomes. And they are just following the LOPD patients, which continue to be asymptomatic with a mean age of 3.5 years and a range up to 5.5 years. So I think by now you understand where I stand. I believe that there is a need for newborn screening for Pompe disease in Ontario and in Canada. And I believe that it is something that can significantly change to the better outcomes for patients with IOPD. So there are most of the patients we will diagnose will have LOPD and probably will just require a follow-up as long as they are asymptomatic, and they can be asymptomatic to adulthood. The fact that we cannot predict when symptoms will occur for LOPD and when patients will require treatment can be very stressful for a new parent that the baby is diagnosed through newborn screening. And I think it is extremely important to understand the perspective of those parents and try to improve our programs and learn from experience published. I find this paper presented now very interesting because a group of 4 different teams from United States looked at the parental experience and follow-up for care for parents of children that were diagnosed with LOPD. Parents reported lack of adequate information, guidance, and psychological support from the very beginning. Overall, 9 parents were interviewed, and they described that they live in a worry not to worry phase when they need to balance between trying to avoid over-medicalizing their children, but at the same time constantly looking for signs for Pompe disease. And the purpose of this study was to understand the experience and to allow newborn screen program to proactively design care plans for parents during this difficult period. And I think that's really important because, as I said earlier, I think there is a great need for newborn screening for Pompe disease patients that have IOPD. There will be a benefit for LOPD as well. If a patient is even just clinically monitored every year or every 6 months, and then if needed, treatment will be initiated in a timely manner, either in childhood or adulthood. But knowing that this is a burden on families, we, the physicians and the newborn screen team, need to work in order to come up with better supports and better plans for parents of babies that have LOPD and are diagnosed by newborn screening. So once we already diagnose the patients, either based on clinical presentation or through a newborn screening program, which I did not say that directly, but we are currently not doing newborn screening for Pompe disease in Canada or in Ontario where I work. We will need to continue evaluation and monitoring for those patients. And again, the monitoring of a patient of a child that have IOPD is a little bit different than monitoring for a child that have LOPD. With IOPD, very early on, we refer to a cardiologist and to a respirologist. Those children many times will require a BiPAP and are in very close follow-up with the respiratory team. We need to carefully evaluate swallowing difficulties, have dietitian to assess those children and provide adequate nutrition for adequate growth. We need to follow up growth parameters and see that they grow according to what we would anticipate they will by plotting them on a growth charts. Patients with IOPD can present with hearing impairment, mainly sensorineural type, and hearing impairment appears to persist despite enzyme replacement therapy, and we need to do audiology testing repeatedly on these patients, and if needed, have early fitting for hearing aids and work with a speech-language pathologist. For LOPD, we usually have them see a respirologist as well very early on, and they usually need regular follow-ups with the respirologist. Some of them will require non-invasive ventilation, and in fact, and this is not just in Pompe, but in other neuromuscular patients as well. That is something that can actually improve blood gas also when they are awake and not sleeping during the day, and not necessarily just during the night. Those patients also need assessment for nutrition, growth, swallowing difficulties, and work on their speech, many times with a speech-language pathologist, and work also with a physiotherapist. And as I said earlier, because of the risk of arrhythmias, we will do periodically Holters or ECGs for these patients as well. Another tool that can be useful in assessing patients that have LOPD is a muscle MRI. And the muscle MRI is a good tool to evaluate involvement, fat replacement, and edema-like changes inside the muscle. And it can be a good tool to evaluate patients longitudinally, and also a marker that can be more sensitive than just physical examination that can be normal, but then the MRI can show mild changes already. And it can be helpful if there is a question on when to start treatment with enzyme replacement therapy for these patients. Both in IOPD and LOPD, physical training and a specific high-protein diet is important. A lot of the studies on physical training came from studies with adults, and this study that was published almost a year ago from the Netherlands group discussed a study that looked for 12 weeks that provided for 12 weeks lifestyle interventions and specific training programs for children that had LOPD and IOPD. Those children were seen by a sport physicians, were followed by the metabolic physicians. Children that were unsafe to do the training program were not included in the study. The team reported that the interventions with the high-protein diet and the physical training was well received by the patients, that many of them are older children, and also their parents, and that it was overall was a safe intervention, and that children with Pompe disease should be encouraged to be physically active to optimize both their physical, but as importantly, mental health. So after discussing follow-ups by a cardiologist, a respirologist, if needed a BiPAP or some cardiac medications, diet, high-protein diet, and exercise, I would like to devote the next few slides to a disease-specific treatment. I will start with IOPD, and then I will discuss LOPD as well. Enzyme replacement therapy with intravenous recombinant alpha-glucosidase enzyme had led significantly to improved survival and motor outcomes. In medical language, we say it changed the natural history of the condition. Enzyme replacement therapy in Canada with Myozyme became available in 2006, and at that time, clinical trials were looking at 20 milligrams and 40 milligrams every other week, did not find significant difference, and decided that the standard treatment dose should be 20 milligrams per kg every other week. But over the years, there is more and more data that suggests that this might not be the optimal dose to treat patients that have IOPD, and that patients with IOPD that have a more severe disease might need higher doses of enzyme replacement therapy. One of the most important papers was published a year ago by the Netherlands team. This team basically looked systematically at 3 different doses of Myozyme for patients that have IOPD. 116 patients were treated with ERT and were included from registries, from a registry that included patients from the Netherlands, France, Italy, Germany, and they compared treatment with the standard dose of the 20 milligram per kg per dose every other week, intermittent dose, which is one of two, either 20 milligram per kg per week or 40 milligram per kg every other week, and the high dose of 40 milligrams per kg per week. The author found that patients that were treated with the high dose of the weekly infusions of 40 milligrams per kg per dose had significantly improved survival when compared to patients treated with the standard recommended ERT dose of 20 milligrams per kg every other week. Additionally, the proportion of patients who learned to walk was the highest on the highest dose group, and followed by the intermittent dose group and eventually the standard dosage group. This paper, and as I said, many other papers before that, led many physicians that treat IOPD to treat their IOPD patients with the higher weekly dose of 40 milligrams per kg. Before we start treating patients with IOPD, we need to do a test that is called cross-reactive immunological material status test, or a CRIM test. Patients with IOPD can be either CRIM negative or CRIM positive. Being a CRIM negative means that there is no GAA protein synthesized because the patient has severe mutations that lead to no production of that protein. Patients who are CRIM positive have some synthesis of the GAA protein. For those patients who are CRIM negative, the enzyme replacement therapy could be recognized as a foreign protein by the immune system of these patients, resulting in developing high neutralizing antibody titer that renders the ERT ineffective. So we want to treat patients and we want to treat them effectively. So what do we need to do in order to do that? So many of you are familiar with the immune tolerance deduction protocols, and those protocols were established to minimize the development of anti-drug antibodies and to maintain low or absent antibody titer over time. At CKIDS, we use the protocol that was kindly provided us by Dr. Priya Kishnani at Duke University. And we use a combination of 3 medications listed here that are provided for a short course together with the enzyme replacement therapy and see good results. For a subset of patients that have CRIM positive, there is also specific ITI protocol that we use. For these patients, we give, again, a short course of only one medication called methotrexate, together with the initiation of enzyme replacement therapy. Treatment for children that have LOPD is not always straightforward. When we look at the general, not just pediatric literature that is out there for LOPD, we definitely know that giving ERT is associated with improved or stabilized muscular and respiratory function, but we also know that it is reported that at the beginning there is rapid improvement followed by some slow regression, and in some studies even slow regression to baseline. So we see some kind of plateauing in the response. However, patients that are treated with enzyme replacement therapy in general are doing better than those who do not and benefit from it. So we want to treat them, but at the same time, we want to treat them at the right time. The American Association of Neuromuscular and Electrodiagnostic Medicine recommends starting ERT in all LOPD patients that have symptoms. And the Canadian expert panel recommends the same, and the European Pompe Consortium recommends the same. Of course, patients need to agree to the monitoring, etc., but we will treat patients that have symptoms. A European consensus looking at the starting and stopping of enzyme replacement therapy for patients, basically reported that there is insufficient evidence to support starting enzyme replacement therapy in pre-symptomatic patients. I think that in North America, and at least in Canada where I work, we follow the same rule. We do not usually start treating patients before the patient has symptoms, and if we diagnose pediatric patients who are asymptomatic, we follow up clinically, we do some testing, but we do not start treatment until we see a change. So until now, I discussed the standard treatment that is available for us with myozyme, but over the last few years, there have been new treatment options available. One of them is alpha glucosidase alpha, which is, again, an enzyme replacement therapy, but specifically designed to be enhanced, leading to a higher enzyme uptake and increased glycogen clearance. Nexviazyme was receiving marketing authorization in Canada for the treatment of patients that have LOPD. However, it is not approved for the treatment of patients that have IOPD. The patients that have IOPD, for them there is an ongoing clinical trial, and there are some reports from the clinical trial that looked at a cohort of patients, 3 different cohorts of patients, trying to evaluate the safety and the efficacy of Nexviazyme in children with IOPD who showed either clinical decline or suboptimal response. And what the team reported after this study is that alpha glucosidase alpha was generally tolerated well by the patients, and they saw positive effect of the drug in patients that previously declined on a standard treatment. And that's something that is true, because I think if earlier that I said that we know that patients respond nicely and then have some plateauing in their response, then it makes sense that if we will change the medication at that time, if patient is not optimally responding or if they are declining, another medication might be more helpful. Another treatment option that is not currently available in North America is glucosidase alpha, which is an enzyme replacement therapy that is also given as a combined treatment with an enzyme stabilizer called miglustat, which is given orally an hour before the treatment with the enzyme replacement therapy. This combined treatment was approved in Europe for clinical use. It was not approved yet in North America, and it is not available for the treatment of children. And there is a currently ongoing phase 3 clinical trial that recruits children age 0 to 18 years. Another exciting study, which was recently published in the New England Journal of Medicine, is, and I'm sure many of you heard about it, is of an in utero enzyme replacement therapy for infantile onset Pompe disease. And the study was done in Ontario, in CHIO, led by Dr. Pranesh Chakraborty, and a team, of course, of researchers from United States, and basically based on family history, they treated a young girl as a fetus from week 24 to 34 weeks of gestation, with a total of 6 infusions every 2 weeks. As soon as this baby was born, as a neonate, she had treatment with the ITI on day 1, and she received a dose of enzyme replacement therapy on day 4. And the team reported that she was doing very well, feeding and growing well at 13 months of age. She had normal echocardiograms, and she consistently demonstrated age-appropriate growth and fine motor development, muscle tone, and power. So it is very encouraging, and it goes back to trying to treat and diagnose patients with IOPD as early as possible. An unmet need for patients that have IOPD is the understanding that patients with IOPD can present with disease in their brain. So, as I said earlier, enzyme replacement therapy changed the natural history of the disease. And in the past, we did not think that patients that have Pompe disease or infantile onset Pompe disease can present with a disease in their brain. But as these children that get enzyme replacement therapy grow up and get older, there is more and more evidence that this can happen. And as you can see, this team did a study for patients with IOPD and looked at changes in their brain MRIs, and there was an increasing evidence that there are MRI abnormalities that are slowly progressive and relate to the white matter of the brain. This can also, patients can also present with some difficulties and show some deficiencies on neuropsychological assessments, including problems with sustaining attention, speed of processing, working memory, and social interactions. And we know that enzyme replacement therapy cannot help with the brain disease, because we know that enzyme replacement therapy doesn't cross the blood-brain barrier. So there is unmet need, and we need better treatment options for our patients. And this is where gene therapy is a very exciting option. In the current era of approved enzyme replacement therapy and implementing newborn screen, there is a need to have a treatment that will answer the unmet needs that we currently see in patients with Pompe disease. It's a major advantage of gene therapy is to provide long-term sustained therapy without the need to give it an infusion every week or every other week. And it can also be a better strategy for various body systems, including the CNS in IOPD. There are few options that can be trialed in and have been trialed in Pompe disease, including the adeno-associated virus and the lentivirus vectors. And there are few studies that are currently looking at gene therapy for LOPD, and unfortunately, none of them are for children with LOPD. There are 3 research protocols that were for adults with LOPD, and there are no currently recruiting gene therapy protocols for IOPD. But as this type of studies keep on happening, and treatment is advancing, and I'm very hopeful that in the future we will have research protocol, and after that clinically available therapies with gene therapy for children diagnosed either with IOPD or LOPD. I would like to summarize my talk now. There are a few take-home messages here. Pompe disease manifests with varied phenotypic heterogeneity, ranging from very early on with IOPD to adult presentation with LOPD. Each subtype requires specific follow-up, monitoring, and treatment. The clinical features of Pompe disease, especially IOPD, have changed drastically due to the administration of enzyme replacement therapy. However, this treatment is not optimal, and there are significant unmet needs remain for patients and their family. Thank you very much for inviting me today to talk with you. And I'm always available. I think that my email address is at the bottom of this slide. If any of you would like to connect with me, I'm very happy to do that. And I'm also happy to take some questions now.
Thank you very much for a really clear and evidence-rich and information-rich presentation. There are some questions, and I'll go ahead and read them out loud. One was more so a comment. There's always a good appreciation for speakers that talk about newborn screening. This is a parent saying that she wished there was newborn screening, and for you to have mentioned that 4 months is still not early enough was very validating and something that she agrees with. Another one somewhat similar was the case that was shared. I think it was the Dr. Chakraborty article that you shared, and they said that there was a case about in utero. And so from your perspective, do you anticipate that that's the way going forward, that there will be more in utero treatment of Pompe disease?
I think that there might be more. I think the group that is, I think, based in United States is doing this study not just for Pompe disease, but for other significant lysosomal storage disorders as well. Soon, if we can treat early and have better outcomes, then I think that the earlier, the better it is. Right now, if we want to do a population screening, we have to do it after the baby is born. And I think that the patients that will be treated in utero probably are treated because there is familial history of a specific condition that can lead to in utero treatment. But I do think that eventually we will see more in utero treatments for those that we think that will benefit from it.
Another question is, it is nice to hear from a pediatrician, a metabolic physician. Do you often work with neuromuscular specialists as well when managing Pompe patients?
Not always. It really depends if it is needed or not. I think it is more based on a specific patient need.
Very good. There are a few questions about the CRIM status, so I'll go ahead and read one. How quickly can you get those results, and if so, where is that provided?
That's a fair question. It takes us something. We send it outside at SickKids. I don't know what other centers in Canada do. We send it to Duke University, and I think it doesn't take that long to get it back. I think maybe 10 days. Yeah. Maybe
Very
10
good.
business days. I don't want to give a number, but I think
Yeah.
the team over there is very quick in giving us results back.
And does that status, the CRIM status of a patient, would you anticipate that it would affect someone's eligibility or ability to get gene therapy eventually?
I don't know. It really depends which gene therapy, who is the target population for the gene therapy. If the gene therapy target more severe patients, then I'm not sure I can answer that question. I'm sorry.
Yeah. The next question here is, what are your thoughts on transitioning patients who are going into adult care? Are there any certain considerations that physicians can think about when transitioning pediatric Pompe patients to adulthood?
I think it is really exciting for me that I can transfer patients with Pompe disease to adult care. It just shows how long we have gone, from the times that we were not able to do that. So it is something that is quite, I think, exciting for us. And at SickKids, we have a program that we for transferring patients, pediatric patients, because we see only children. Once our patients are 18 years of age, we have to transfer their care to an adult center. So the program that we have is not specific for Pompe disease, but it is, for all of our metabolic patients. And, many times they go to have a meet and greet at the adult center. They meet a genetic counselor, I think when they are 17 or so, to make sure that they are informed about their conditions, the genetic variants that were found, that they are informed about the manner, the mode of inheritance. They meet our social worker that makes sure that they are informed and understand the conditions that they have, and have many discussions with us, with me, with the nurse, with the team that take care of them as well. And then we have a specific timing when we transfer care for the adult team, just to make sure that care will be continued with no disruptions. And, each team will also do their own transfer of care. So the cardiologist will refer them to an adult cardiologist. The respirologist will refer them to an adult respirologist. If they need any coordination of all of that, then we are always happy to help with that as well. But that's usually happened by other teams. I hope I answered the question.
Yeah, absolutely. That is interesting, and the family that's commenting is saying that they too didn't expect to even be talking about transition, but that is so exciting for them to be engaging in something
For
that they
us
didn't
to,
anticipate, and for the clinicians as well to hear that as
yeah.
well. We'll take one last question. Hopefully, I'm saying or reading this one correctly, but maybe I can rephrase it. When thinking about Pompe disease, do you agree that there is such a thing as pre-symptomatic patients, pre-symptomatic Pompe patients?
For sure, I think that many of the patients that have LOPD are pre-symptomatic. They do not present with symptoms until much later. For various reasons, sometimes with newborn screen, we will do it much more. We will diagnose them as young children. So I think as long as the patient is pre-symptomatic, we just need to see them once in a while, do a good physical and neurological exam, maybe do some testing that relates to pulmonary function tests from time to time, or EMGs, and just make sure, send some blood work and make sure that everything is okay. And as long as the patient is fine, well, active, do not have any complaints, and for example, about fatigability or exercise intolerance, or problems with walking distance, specific distances, etc. There are specific questions that we usually ask. Then we just need to continue follow the patient. And I always say that, you don't have to think about us. You see us once or twice a year, and then you can forget about the metabolic doctor until you see them the next time. And of course, if the parents see any changes between two different appointments with us, they can reach out to me or to the nurse, and we can always see them sooner.
Absolutely. So on that note, I wanted to thank everyone for their time today, and thank you again for a clear and very well delivered presentation. I can already see from the comments, this is exactly the type of information that they wanted to hear about, and the perspective from your background and your expertise. So wishing everyone a great afternoon and a great day ahead. Thank you all so much. Have a good day.
Thank you. Have a nice day.